So delighted to introduce Trudy Lieberman. I'd like to thank Nora Lou Roos and the Evidence Networks people in Manitoba who have facilitated a cross-Canada visit for Trudy, and we're just lucky enough to be able to benefit from her visit to Toronto. Trudy is has been a journalist for over 40 years in the U.S., worked with Consumer Reports for quite a while, past president of the Association of Healthcare Journalists, is a associate professor of public health at Hunter College in New York City, so I think you get the sense that she's an experienced healthcare journalist. We're going to sort of pull a bit of a curveball on you here because she's going to spend part of her time talking about what the title says she's going to talk about, and then she's going to spend a bit of the rest of the time giving us a sense of what Obamacare in the U.S. really is about and where it's going, because I think you're finding that when you've talked to people here, they're pretty interested in that, and I think that there's an audience that would be interested in that as well. So, but the official title here is Talking to the Press, Communicating Your Research to the Public. Trudy, thanks very much, and welcome.
Thank you. So I hope you don't mind that we're going to change the topic just a little bit today, but I'm finding as I go across the country there is incredible interest in the U.S. and the health reform there and what it does and what it doesn't do. And I'm finding that as I tell people what Obamacare is like, and they're saying things like, you know, we really haven't heard much about it, or we're very confused about what it does, and some people think it's more like Canada, which it is not. And so there's a lot of interest and some misconceptions, I think, about what it does. And there are many misconceptions in the United States about what it does. So I'm going to talk about that. And in my role as a press critic, I also cover the coverage of healthcare and examine it for the Columbia Journalism Review. And I've been doing press criticism for CJR for the last 20 years, first in long form for the magazine, and in the last few years doing it all online. And I really much prefer the blog format to the long Consumer Reports style that I was schooled in for so many years. It really gives you a lot more freedom. So I'm going to talk a little bit about what I've learned as working with the Association of Healthcare Journalists in terms of how to get reporters to do a better job of writing about research, whether it's health policy research or whether it's medical research. And as I thought about this, the topics really kind of converge. I mean, I think when you think about the research, whether it's a new drug study or a new intervention to make care better or whatever, or whether it's discussing the insurance system of a country or wait times or any of these health policy issues, I think the takeaway for research is probably the same. I should start off by saying that I'm a reporter that does not get a lot of press releases and notifications about new research. In fact, the RAND Corporation for a long time did not send me their press releases. That's one group I like to follow because sometimes what they do is worth reporting on. So I had to call the communications guy and say, hey, you know, remember me, I'd like to know what you guys are doing. So he said, oh yeah, it's just an oversight, we'll put you on the list. So with the exception of RAND, and JAMA, I'm on their list, I don't get very much of this stuff. I think largely because I don't cover clinical stuff very often. And number two, I am kind of skeptical. And so all these organizations that have research or they're trying to tout a new product based on what they claim is evidence don't really put me in the loop. And I should say that the Department of Health and Human Services in the U.S. doesn't send their press releases and their information to me either, as they do most reporters. And I only know what they do because I have a reporter who sends her stuff on to me, thinking that I might want to know what HHS is up to. And I think that that says a lot about who these organizations want to target their press releases, their research to try to get publicity. Because I think they know I'll either ask too many questions or I'm not going to do anything with it. So that said, there are a lot of organizations that have sent me stuff, and I'm going to tell you a little bit how I, as a journalist, use it. And the takeaway for all you is that maybe other reporters will see things in sort of the very same way. So in the last year or so, I've gotten lots of information from an ENT practice in the New York City area. And they apparently have bought a lot of new technology to diagnose whatever they look for in the throat. And they're always talking about the press release touts this new intervention or this new way of diagnosing. And then they also tell me that they have set up clinics all over the city of New York. So you can go to this one in Brooklyn, you can go to this one in New Jersey, which is not in New York, but it's in the metro area, and you can go see one of their lovely ENT docs. So I guess I did write about that one, because what it illustrated for me is that it was pushing services, and that we have a lot of practices in the U.S. pushing services. So this is a very relatively new thing that I've seen in the last few years. Another one that I've seen fairly recently was from a group called One Health. And One Health is a boutique medical walk-in clinic aimed at very young people. And so they are advertising on Facebook. I see them on Twitter a lot. They send out press releases. And what they're looking for are patients. And so they want new patients to come in. And while they don't have any research that they're really touting at this point because they're new, they are talking about how easy it is to get a doctor, how long your wait will be, which is negligible. Apparently they don't have any waits there. And then they say they take all insurance, even Medicare. And then I look at this, and in the fine print, you can see they really don't want to take any Medicare patients because they're not looking for any old people to come into their practice. So they don't want to do anything that's going to be too time-consuming, shall we say, if you accept the premise that people over 65 have more conditions and more things that they have to look at. So I called them up before I wrote a story about them and asked them, well, do you really take Medicare? And they said, oh, yes, we do, but we really do want younger people into our practice. So the question in my mind was, if somebody, an older person, saw this, would they really get very good treatment there, or would they be sent on to somebody else? So those are the kinds of questions that I use and think about when I get these kinds of press releases. And what we've been trying to do at the Association of Healthcare Journalists is to get reporters to be very skeptical of the research and to be very skeptical of the press release that touts the research. And usually the way this manifests itself is from drug companies. I don't know whether you get a lot of that in this country or not, but we have press release after press release from pharmaceutical companies and related image makers and people who are selling devices and want to get them used. And so what we had for a very long time was this research was kind of being touted. There's this new study comes out, and it obviously talks about the positive aspects of the treatment. It doesn't really discuss the difference between absolute and relative risk. The Association for Healthcare Journalists does panels all the time on this to try to talk about sensitivity tests, absolute value, absolute risk, relative risk, and how you should really look at both of them if you're writing a story and not just look at the relative risk, which is what often is in the headlines. So we've worked very hard to get reporters to be very skeptical of those kinds of press releases. Unfortunately, we're not totally successful. And I think all we have to do is look back to the Vioxx business of a few years ago and the whole COX-2 inhibitor problem, and how the media just really blew that story because they did not look skeptically at the research that was coming from the drug maker, or they didn't even look at the research that was beginning to question the value of Vioxx and whether it was causing heart attacks. So what we did at Consumers Union was to do a timeline and showing where the evidence was coming out in JAMA or New England Journal, wherever, beginning to question whether this is really what the press should have been covering. So I always like to use the Vioxx example and then the restless leg syndrome problem as examples of organizations that are pushing research onto the press. And they are excellent examples of why the press shouldn't pay a lot of attention to this. I think what we try to say is that you really don't necessarily want people to take some of these drugs unless the drug has been on the market for a while, because you really don't have a track record for it. And reporters all the time are getting confused by the comment in these press releases or in the research saying that this has been approved by the FDA. So just because it's approved by the FDA, it's fine, it's gone through all kinds of rigorous testing, and it's okay to use. And the medical doctor at Consumer Reports, where I spent most of my career, said I would never recommend anybody to take any new drug unless it has been on the market at least a year, so that we know what kind of side effects and what kind of problems result from it. So the press at that particular time used to say, well, we're going to write about this, but we're not going to say this is really a new drug. We don't know whether it has any track record, and every drug has a side effect, so why should we pay attention to any of them? You know, they all do the same thing. Well, that didn't turn out necessarily to be the case with the COX-2 inhibitors. And with restless leg syndrome, which was pushed a lot by the sleep industry and the makers of sleep pills, the research, some researchers from Dartmouth tried to counteract that and say this is not anything the media ought to be writing about. But they did, and it took a long time before the educational component on my end sunk in that, you know, you have to be very skeptical about what comes across your desk. So what is coming across your desk, well, our desks right now, and I'm often asked by researchers what should they put in press releases, because we know right now that there is a great deal of pressure to get hits in the media, so to speak. And you know, I understand the whole publishing business in the academy and research organizations, and most reporters will tell you that they get hundreds of these over a 2 or 3 month period. And I was talking to Teresa Boyle from the Toronto Star today, and she says, I just get hundreds of these and I don't pay any attention to most of them. Unless her editor or an editor at any television outlet, mostly, or radio, or perhaps even in the newspapers, says, well, we heard about this great wonder drug, we really ought to write about it. And you often see in American television that the network news people are writing about all of these drugs and wanting stories. And the one that I remember very clearly was Aricept when it first came out, and it was being touted as a cure-all for Alzheimer's disease. And I think that's not what the study showed. I think it showed that it just slowed progression for a while, but after some period of time, that there really wasn't much difference. And so whenever I find a family, or I've interviewed a family, and they said, well, they had mom on this drug for a while, my first reaction is why? And then number 2 is, did it do any good? And when they say that, I said, well, at what point did you realize it didn't do any good? And they said, oh, you know, after a few months, there really wasn't any difference. And I think the literature showed that, at least when the drug came out. So if there's been a change, please let me know during the Q&A. But this is an example where, another example where I think the press really, really pushed this drug over the top and got families, and then physicians were prescribing it, and it sort of got into general use. So what we have coming across our desk now is what we like to call study says stories. And some of my colleagues and I have talked about this at Academy Health in the US at some of their interest group meetings about translation and communication and how you get your message across. And my colleague Julie Appleby, who now works for Kaiser Health News, says, I always tell reporters not to pay any attention to those kind of stories, those kind of studies, because how do we really separate the sheep from the goats on which studies we really want to look at? And the sad truth is that reporters don't have a lot of time to look at the evidence. So from the point of view of researchers trying to get their message in the media, they kind of have it pretty good, because all they have to do is write a very provocative headline, and in the lead of the story, using relative risk as the metric, this particular intervention cuts the risk of X by whatever, and we found this kind of savings if it's a health policy intervention. And reporters generally don't go beyond that. And in preparation for this talk, I asked Barry Scholl at the Commonwealth Fund in New York, who's a very good communications person. And he's also a friend of mine, and I asked him what he does. And he's spoken to my classes before at CUNY, and he said, well, we don't necessarily not tell all the negative results of whatever we're trying to talk about, but we've just learned that you put the good message right up top in the lead of the press release. And so when I've had him come to my classes, I've asked him to dissect a press release. And that's been a very revealing kind of exercise for my students, because I make them kind of look at the press release and say, well, what is it that you're really getting here, and how would you interpret this? And so he says, well, that's just how we do it, and if you read the rest of the press release or you go to the issue brief or the study, you will find that there's more nuance, and that you will find it's not quite so black and white. And so I think what researchers have on their side is that the media doesn't have time, reporters don't have time, to look at all these ways they're putting out information. The actual study, the long form, the issue brief, and they tend to just look at the short form, which is the press release, and maybe make one call and cobble together a story. And TV is much more guilty of that, I think, than newspapers are, but not entirely. So I think we have, in this case, sort of two competing interests here. And the wisdom that I would pass along to you in terms of communicating your research, and that's not to say we as journalists don't want to hear about your research. We probably do. But not all research is created equal. And some things that you do have more public relevance than others. And I think some things that are really kind of difficult or very nuanced, and I can't give you an example offhand, I think that's probably not going to get a lot of receptivity among the media, given the fact that people like Teresa are getting hundreds of these press releases, every couple of months. So the first rule I would give is to make sure what you're trying to communicate is really worth communicating. And not everything that you do is probably going to fall into that realm. And then given the fact that reporters don't have a lot of time these days to sift through and look at the studies and really understand it, they're probably not going to do that. So only really think about sending out what has good relevance to you. And I'm going to give an example from RAND, because this was a study that they did not get picked up by the press and should have. They did some work on the effect of high cost sharing on whether high cost sharing was a deterrent to getting care. And they found that in some ways it is. And depending on what side of the political spectrum you are on in the US, that may be a good thing, because it's the way we want to control costs. We want to make it more difficult for a lot of people to access it, and we do that through the cost-sharing mechanism. But it was also a relevant study in terms of the fact that people were not getting services. And this wasn't preventive care services, because the study design dealt with employers or insurance companies that were paying for the preventive services. So this was not preventive care. So it had more relevance in that sense. So people were using that as a deterrent. It was a deterrent. The high cost sharing on these insurance policies was a big deterrent to getting care. So I thought that was a very newsworthy story and study. And I called the PR guy at RAND, and I said, did you get much pickup on it? I didn't see any when I did my Google searches. But, I could have missed something. I don't see everything. And he said, no. He said, I think a few of the trade pubs were very interested in covering it, but not any in the lay press. So I sort of wrote a post about it for CJR and sort of said, here guys, here was a really relevant story that was not really picked up and probably should have been, because this whole issue of using the cost mechanism as a way to cut down on volume and use of services as a way to control costs is very relevant to our discussion. So that was an example where one should have been covered and wasn't covered. In the last weeks before the Obamacare Act took effect in October 1, there were too many studies out on, they were good news studies about the low premiums in the exchanges. And when I switch in a minute to Obamacare, I'm going to talk about that. And they were very one-sided. And even though they came from reputable groups, or ordinarily people you would think twice about looking at their research, after a while I got to thinking, something's wrong here, that they're all kind of saying the same thing. They all kind of want to get in the act. They want to make the point that this is going to be affordable insurance, and for a few people, and some people it might be, but for a lot of people it's not going to be. And they wanted to get out a message, a one-sided message. And some people in the media picked it up, but I don't think they got as much press with that as some of them may have hoped. So that was, at least from the journalism side, a good omen. From the side of the foundations and others who were putting out this information, it may not have been, such great hits for them. But my guess is they got some. So aside from what is newsworthy, and I think if you're going to think about that as a standard, you have to think a little bit about what would be newsworthy to you as an ordinary person. Take off your doctor, your medical hat, health policy hat, whichever one you wear, and say, if I were an ordinary person, would this be relevant to me? And what would I want to know? And I think that's usually a good standard for deciding what press releases you want to, or what research you want to put out. As a journalist, I've learned early on that as a consumer writer, which is what I've spent a lot of my career doing, putting myself in the shoes of a shopper buying health insurance or Medigap coverage or life insurance after my daughter was born, what did I as a shopper need to know? And if I used that standard, I found that I could write a really good story because I knew what to ask. I knew where they might not be answering my questions, and I could communicate that to my audiences. And I still think that that's a very good standard for journalists as well as researchers. Two other points that I think are really relevant here, and one is to be clear about what this is all about. There tends to be too much nuance, and I know that's research often shows. But the nuances really kind of get in the way of clear writing, I think, sometimes. And the writing has to be really clear in the academic work as well as in what you send out to the press. And in communicating with the press when they do call, and they will call, I think it's really important to be really clear. Boom, 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 this is what it does, this is what it doesn't do, this is where the nuances are, and then the relevance and the context. And why is this particular study important in the context of all the other studies that have been done? And my colleagues and I are always trying to teach reporters to, when you evaluate a study, say about drugs, for example, a new drug, or a new imaging machine, what does that look like in the context of other studies that have been done on the same topic? And it's very, very hard to get reporters to kind of look at this context because they don't have time. They don't have time to make the next call or to do a PubMed search. We're just barely teaching people how to do a PubMed search. But that's really important. And I think if you're talking to the press and they don't ask you about the context, you might want to supply that. Anything you can do to help the reporter do a better job of conveying what you want conveyed, even if it means they may not necessarily write the most positive story you want out, but they might write a good story that might be helpful to people in the long run. But I think they need this context. And too often I find in my critiques that reporters aren't looking at the context, particularly in drug coverage and particularly in new machine coverage and in health policy, simply not looking at the context. And the other thing I would recommend is that we look at conflict of interest. And I know that the journals are much better now about requiring disclosure of conflict of interest. And I think the press is really mixed on this. I had someone from the New York Times once say, I was with a science editor on a panel once, and she said, we know we should say the conflicts, this guy had conflicts or he got money from the Heart Association or wherever these came from. And all that's kind of disclosed right now, in a JAMA article, New England Journal, and even some of the other journals. So it's out there. But the reporter from the Times, or the editor from the Times said, I can't clog up my story with all these long disclosures about 4 different authors on the study, and they all may have different disclosures or different conflicts. So I think that presented kind of an interesting conflict for journalists, and how do you deal with this? So I think one way that some reporters have dealt with this is to say a study largely funded by X, or a study funded by the NIH. So at least something to clue the reader in that maybe this study might have been funded by the government, or maybe the study was funded by pharma, or GlaxoSmithKline. I mean, these things are very important. And I think the challenge for us on our end is to teach reporters that, a study funded by GlaxoSmithKline may be one you want to take a second look at, because what's not left out, what's the endpoint they're talking about? Are they really talking about an intermediate endpoint? They never really got to their endpoint. And so those basic concepts, I think, need to be talked to and talked with the journalists who you're writing for. And I think that will go a long way on both sides to getting out your message, as well as helping journalists do a better job of putting all this in perspective for the public, and whether they should go and ask their doctor for the latest and greatest, because they're hearing that and they may not hear the counter. And I was teaching at Case Western for a couple of semesters in the mid-2000s, and I always gave the students exercises like watching the ads on TV and then reporting back what you saw. These were just random students. They were taking this ethics class because they probably needed to fill a hole in their schedule. And one kid whose interest was in pop music, he was not health, journalism, or anything. He was interested in music. And I sent him out to look at the Viagra commercials. And he did. And he came back and he said, I watched this and it said that you could go blind from using this drug. What do they mean? And I said, well, they were disclosing all their side effects, but why don't you call the consumer hotline? I think that's I think it was an Eli Lilly drug, whatever. Is that Cialis? Is that the one? I don't know. I don't remember. But that was the one. So he called their hotline, and he talked to the consumer representative, and he said, I heard this on TV. What do you mean by it? And she said, oh, it does not really apply to our drug. It applies to our competitor's drug. That using our drug, you will never go blind if you use it. So the student came back and he said, I didn't believe a word she said. And I said, good, because that's exactly what you should have taken away from this. So I think that this kid in my class is the one you really kind of want to reach, so that he can be skeptical, can understand your research, but be skeptical of everything else that's out there. So I think it's kind of an interesting challenge. And I'm going to switch a minute and talk about Obamacare and for about 10 or 15 minutes, then we'll have questions. Because this is a law that was largely sold. And when we talk about how to sell something, I think that, or how to get the message out, I think this is an example of really, I would say, a success story on the part of the advocates for Obamacare and the administration, that, and the Democrats to some extent, in selling this brand of reform to the public. And they did it through polling, and they hired pollsters that told them to talk about affordable quality health care. And the Democrats pretty much stayed on message throughout the whole debate and in the years after the act was passed. You still, to this day, see some people talking about affordable quality health care. And the fact is that it's not necessarily going to be affordable for a lot of people. So people finding out that they're really going to have to pay a fair amount of money if they want a good insurance policy in these shopping exchanges, it may not be so affordable for them. And what kind of backlash will there be? And so I think that they used that. People believed it. The press reported over and over again without being skeptical of what it meant. And I think to this day they've had, because they were so good at staying on message and they were eager to give quotes to people, and they really narrowed the discussion on it, that things people needed to know about what the act does and doesn't do really were not part of the discussion. And so that's making it very difficult, I think, today to push back against this incredible backlash that the law is having. So I will briefly talk a little bit about what it does and what it doesn't do, and then you'll sort of see what I mean in this context. It is not wholesale reform of the U.S. healthcare system. It is not single payer, and it's not socialized medicine, as a congressman from Alabama inferred in the New York Times last week. He said there was more than one way to get at the deficit besides socialized medicine. He didn't say like Canada, but others do. So we have that issue to deal with, but it is not any of those things. It builds on the private insurance system, which is private delivery. The delivery system hasn't changed at all. If anything, the law may speed up the conglomeratization of many healthcare systems and the hospitals in the U.S. And you can see that they're sort of beginning to own doctors now, and there's sort of a transformation on the ground going on. But it's not government-run anything. The insurance companies, private insurance companies, are still in the game, big time. And the most important thing is that the employer market has not been disrupted, and that was the major goal of the employer community. 160 million people get their insurance from their employer. And that, up until recently, has probably been pretty decent insurance. It's changing now as this cost shift to the consumer or the patient or the worker is happening, and it's happening a lot. So it's becoming less good for people, and I think they're beginning to be aware of that shift, but still, they are very big players. And the employers did not want any change whatsoever and worked very hard behind the scenes during the debate to make sure that didn't happen. The doctors and the hospitals are still very much in charge of the system. The proponents of this law decided to demonize insurance companies as a marketing strategy, and it was probably brilliant because Americans don't like insurance companies very much because they deny claims, and there have been all the anecdotes about people not getting care and dying and all this kind of stuff. And during the heyday of managed care, it was that women could not get autologous bone marrow transplants. Didn't matter whether they worked or not. The HMOs were denying it, probably rightly so, because it didn't work very well and was very expensive. But the horror story was these people were being denied care. So that is very ingrained in America. So they don't like insurance companies. So it's very easy to demonize them and say, you know, they're terrible people. This is why we have to have this reform. But there was a question that wasn't asked. If they are so bad, why are we sending 30 million new customers to them? Because that's what Obamacare was supposed to do. So nobody really in the press made that connection between, you know, if they're bad, why are they getting more? That seems to be a pretty elementary question people ought to ask, and it was never asked. And it didn't serve the purposes of people who wanted this law because they thought that was the best they could get. Even the old single-payer crowd didn't think we could ever have Canadian health care. So they signed on to this. So what do we have instead? We have a system of reform of our individual insurance market. And this was a market where people would buy in if they had no employer coverage or no Medicare or no Medicaid. And they often didn't get a policy because they had pre-existing health conditions. And it was a very perverse situation, and I'd written about it many times. And so how that worked was that if you were really sick, you didn't get any coverage. If you, say, had asthma, you might get coverage, but not for diseases of the respiratory system or the lung. Companies did it in different ways. Sometimes it was the whole body system, sometimes it was just the body part. Kids with ear tubes didn't get coverage either because insurance companies thought, they don't want to pay for these chronic earache problems in kids. So it was not working very well, and it was very expensive for people who had to shop in it, prohibitively so for many people. So basically, Obamacare changed that marketplace. There are no longer restrictions on pre-existing conditions. Insurers can charge older people 3 times more than a younger person, though, age being a proxy for poorer health. A 58-year-old may have more chronic conditions than a 28-year-old. So they can underwrite still for that, and they can underwrite for smoking. And so if you're a smoker, you're going to get charged a lot more, and they can charge you based on geography. So the way it worked in Massachusetts is that in Cambridge, people paid a lot more for their health insurance through the connector than they do in the Berkshires. So there were these geographic rating schemes that were happening, and that was not well understood. So people shopping in the exchange were also getting subsidies. These subsidies, 40% of people in this individual market now, and that's going to be between 24 and 25 million people. About 16 of them were already in this market, so the rest of them are new people coming in. 40% of them won't get any subsidy, but 60% will. And for many people at the low end of the income spectrum, that will be very helpful. So if your income is 250% of federal poverty level, you'll get a pretty decent subsidy to buy a policy. If your income is 400% of poverty, which is $94,200 for a family of 4, you won't get much of a subsidy. So the real fear is that people in the middle, the median income in the U.S. is around 51, 52, 53,000. But people in that group may find the subsidy very inadequate to buy a good policy. And by a good policy, I'm talking about something that may cost $16,000 a year, which is the average employer policy, a good comprehensive policy. So we don't know how adequate these subsidies are going to be over time. They're indexed to wages, not healthcare prices. Prices always go up faster than wages. So we don't know whether those subsidies are going to keep up with inflation. But for now, people at the lower end can get coverage and get a pretty good subsidy. So what else does this do? These policies available on the exchange come basically in 4 types. We call them the heavy metals, and perhaps you've heard this term. I know this sounds really foreign to Canadians, so I'll take you through it step by step. The lowest policy, the cheapest one you can buy on the exchange, is called the bronze policy, which will cover only 60% of your medical costs. The next one, the silver plan, covers 70%. The gold plan covers 80%, and the platinum plan is 90% coverage, and that will be offered, but not in very many exchanges, I think, because it's going to be really expensive. The thought is, and this is true in Massachusetts, is that most people buy the lowest policy, the bronze level policy, and then their second one up, I don't remember whether it's silver or gold in Massachusetts, but the thought is that most people will buy either the silver or the bronze plan because, it's relatively cheap, and especially for younger people, and so that might be enough of incentive to get them into the risk pool, and you need to have a big risk pool to make any of this work. In Canada, you don't have to worry about it because sort of everybody's in the risk pool. So the sick people are subsidized by the well, and the poor people subsidized by the wealthier, and the older by the younger. And that's that solidarity principle that's part of our Medicare program, your Medicare program, and all the European systems, but not our commercial market. So what we have to do is try to entice these young 27-year-old non-smoking men into the risk pool. So how many Americans really want a policy that covers 60% of your costs? I would think not very many. But again, I'm very risk averse and I want as much coverage as I possibly can get. And I was under good coverage almost all my career. So I know the peace of mind you have from having good coverage. So how are they going to achieve this? And I think this is where I see some convergence maybe with the Canadian system, and there's actually a lot of similarities here. But what we have are co-insurance and co-payments and deductibles. And I think you have some deductibles if you buy private drug insurance. Is that part of what you get? Yeah, and a drug benefit you pay privately for. Okay, so you know that concept. I was giving this talk in England a couple of years ago, and nobody knew what a deductible was. So it's the amount you have to pay out of pocket before the policy pays. And those amounts have been going up really high in the U.S. the last 2 or 3 years. So it's not uncommon to find deductibles of $10,000 for in-network services and maybe $20,000 for out-of-network services. So, you know, that's a whole lot of money that people are going to have to pay out of pocket if they get sick. Not everybody will get sick, and someone takes one of these plans and never gets sick will do very well. But if you do get sick, and it's very hard to predict illnesses, even for 27-year-olds, it's could be dicey. So they do it through the deductible, and they do it through co-insurance or the co-payment. Now, the co-payment, you might know, is just a set amount for a service, a few dollars that you have to pay. In the U.S., they were historically low. $5, $10 to see a doctor, maybe $40 to go to a specialist. So most people got used to that, and they said, oh, this is not such a big deal. I can pay $30 or $40 to go see a GYN if I needed one. However, the industry has changed, and they've done it very subtly and are starting to shift people to co-insurance, which is a very different animal. The co-insurance is a percentage of the cost of a service you have to pay. And it's not uncommon now to find 20, 30, 40% co-insurance on the most commonly used services: hospital outpatient care, outpatient surgery, urgent care, emergency room care. So that's where they're putting the cost shift to the consumer. So suppose you have cataract surgery done in an outpatient setting, because that's where most of them are being done, and costs a couple $1,000s, I don't know what it is, something like that, maybe more, depending on the kind of lens you buy. You may have to pay 50% of all that. The hospital's fees, the 50% of the doctor's fees, whatever the insurance company calls for. So I think people are not aware of that, and so they don't, you talk to them and they say, well, I can pay the copay, but they don't realize the difference. And you look at their policy and point it out to them and explain it, and they begin to think twice, and they have all this cognitive dissonance because they thought it was one thing, and now I'm telling them it's another. So what insurance companies are doing to get that 40%, 70, 60, 80, and the 90 is to mix and match those three elements. So the challenge for consumers now in the exchanges and in the employer market as well, because employers may present this menu of options and you have to make the same calculation. So you have to think about, do I want to pay more up front, or do I want to pay it if I get sick? So that means if I buy a policy with a higher premium, this cost sharing is going to be a lot less. So do you prefer to be covered at the front end just to protect yourself from this risk that you could face, or do you want to take your chances and pay a low premium up front and face this 50% co-insurance business at the back end? And that's a very, very difficult calculation for people to make because they can't predict their illnesses. And if you're a family man and you have, or woman, and you have a couple kids and they play football, they could break a leg or they could fall off a bike. You know, these things happen. And I use this example of an insurance agent in the Arkansas Delta region near the Mississippi I was interviewing a couple of years ago. And he said, I would give up my insurance part of my business for single payer Canadian health care any day. And I said, well, that's an odd thing for you to say. You're in this business. Don't you want to sell health insurance? He said, I can make money selling auto insurance or property casualty or life insurance, annuities. I don't need this business. He said, this is my stack of bills. It was like this high. And he had 4 kids, or 3 kids. They were well insured through the Arkansas University system where his wife worked. So they had really good insurance. He said, I can't pay these bills. So this is somebody who has really good insurance facing this out-of-pocket expense that the Arkansas school districts, university system, imposed on their members in their insurance. So I think there's going to be a lot of people kind of not understanding what's going to happen when all this kind of shakes out. And the other point I want to leave you with before we have some questions is the cost control mechanism in the Affordable Care Act. There's not a lot. There is some talk of accountable care organizations, and if they can manage care in a given population more effectively, there is some potential for managing and lowering costs and improving care, and especially coordinating care better. And I think the evidence so far on them has been mixed. And so I guess the answer is we really don't know how well they're going to work yet. And it's very hard to describe exactly what these are. And it's like one of my colleagues said, it's sort of like a unicorn. Everybody thinks they've seen one, or they know what it is, but they've never seen one. So in some locations, people are not going to be seeing accountable care organizations. For example, the state of Nebraska, the state of South Dakota, there's probably not going to be a lot of that there. So the cost containment is kind of iffy in the law. And I'm understanding clearly about your system that the power of the providers kind of prevails here, and it really still prevails in the U.S. So will this work? I think people are always asking me if it will work. My answer is I don't know. I think we're going to need at least 2 or 3 cycles of insurance and see what the insurance industry is going to do with prices and whether people are going to go into the risk pool and whether it's going to work. And it may work in some states quite well, perhaps California, perhaps New York, perhaps Connecticut, but I think it's going to work less well in places like Mississippi or Texas or South Dakota, where there's not much government support from the legislature or the governors, and people have visceral reactions to this law. So I think it's just going to be a wait-and-see proposition. So I think we have a few minutes, and I can answer questions about that. There have always been a few of them, and as well as communicating your research. And I think, again, Obamacare is a good example where I think the proponents of it did quite a good job. And probably didn't explain things they should have, like the individual mandate, why it was necessary, why there's some wealth redistribution in Obamacare, not a lot, but some, and the insurance companies and the business community are paying higher taxes, and very wealthy Americans. And there's a backlash now against that, and the medical device makers are running around saying, we've got this tax, we've got to get rid of it. Insurance companies want to stop the health insurance tax, and they have big lobbying campaigns going. And that resonates out in the country. And, why are you taxing business? This is terrible. Well, somebody has to pay for the subsidies, right? So that transfer of wealth was never really explained to people. And I think that's largely a press problem, and I think it's also a problem of the administration not really wanting to bring up all those negative things about the law.
Thanks. Open it up for questions.
Yeah.
Thanks so much for your presentation. Just a couple of questions with Obamacare. I was wondering if you could speak to my understanding is that states were offered an increase in coverage for Medicare and Medicaid
Oh, yeah.
Some states, particularly Democrat-controlled states, took that, but the southern Republican states didn't.
Yeah.
So it'd be interesting to hear, or like what the impact. The other question I had is, as someone in public health, I understand there's a lot of new funds actually for public health and preventive services in the Act. And I don't know if what your thoughts are.
Okay, I'm going to talk about both of them. Thanks for bringing up the Medicaid problem. It's, I think, the Achilles heel of this whole thing. What happened was that the expansion of coverage was not only in these exchanges in this market that I described, but also states were supposed to expand their Medicaid coverage to people up to 138% of poverty. The Supreme Court said the states could decide what they wanted to do, and they decided they didn't want to do it. So 26 or 27 states have refused to do this. And the perversity of this is that people who are below 100% of poverty have no options. They are barred by the law from shopping in the exchanges and receiving a subsidy. They're too poor to buy their own insurance at $16,000 or even $5,000. And states' Medicaid programs often don't include childless adults. Most of them don't. So the people living in the southern states, the Midwestern states, some of the Rocky Mountain states, have no options if they are the poorest of the poor. And a woman was quoted in a New York Times story a couple of weeks ago saying she had moved from Maryland to Virginia because she'd lost a healthcare job in Maryland, went to Virginia and to live with family because she was really poor. And she told the Times reporter rather tearfully, she said, "You mean that I have such low income I don't qualify for subsidies?" Because that's not the way it usually works with means-tested income-related programs. It's usually if you're above the line, you don't get the subsidy, right? So now it's if you're below the line, you don't get the subsidy. So there's probably going to be, I think they were expecting about 15 million people to be affected by the Medicaid expansion. And some portion of that, 6-7 million, are in those states. So those people are really out of luck. And the governors and the legislatures in those states have just said, no, we don't want any part of it. It's very hard to understand their reason. Some of it may have latent racism. That may be part of it. Others just say the federal government's not going to keep its promise and pay our bills on this. And some just don't like it. And it's very hard. And I think it's going to make a difference, I think, long term, how successful this law is. Because, doesn't this sound weird to you? People who are so poor can't get the subsidies. And it's hard even for the media to explain it. Now, the question about preventive care is also an interesting one. There are some preventive benefits that are built into the law, particularly for Medicare patients. They've been really underutilized. Now, on the other side, there was a big prevention fund set up, but the Secretary of HHS had to raid it recently to get the money to pay for navigators, helper people who are supposed to go around in the states and help people enroll, neutral people supposedly, and sign up for Obamacare. So I don't know how much is left in the prevention fund, but that raises a good question. I should urge my colleagues to do a story on it and find out. So I don't know how much prevention is going to be there.
Other questions? Karen, and then Yvonne.
So we've talked a lot about the kind of press release journalism in healthcare, but one thing that you didn't talk about, or maybe you alluded to it a little bit, was the kind of pro-Obamacare journalism. How would you characterize the, Atul Gawande type, almost opinion healthcare writing, as well as, New York Times has been running a series, Paying Till It Hurts, I think it's called. They run some pretty strong opinion-based pieces on these subjects, so we'd be interested in your point of view on that.
Well, I think, what I do is opinion journalism too, really, right? And I think that, you probably get a fuller explanation of what's happening in some of these opinion columns, but then some of them are quite biased on one side or the other, and I think you really need to understand. The guy at Forbes, Avik Roy, writes pretty clearly. He's explaining issues fairly clearly. He's a pretty good writer. But he's clearly coming from a point of view, and he doesn't want any part of Obamacare, and they will look for anything to kind of discredit it. There's a lot of those people on the other side, the non-conservative side, that have pretty much bought into Obamacare. Even people who once supported single payer. You don't find anybody talking about this. And from my own experience in writing about this during the debate, there was a blogger for one of the foundations, and she wrote to my editor and she said, please tell Trudy not to give any ink to the single payer crowd because they're going to stand in the way of us getting this. And we need this. This is our only chance. And one of my colleagues who wrote an aging column for Newsday had the same experience from the lobbyist for AARP, who said, please don't write about the single payer crowd. For a while they were kind of active and they were legitimate news, and then they just kind of faded away. But they were fairly visible and they merited some coverage. And the lobbyist for AARP said, you know, please don't write about it. You're going to block our chances. This is our only chance to get health reform. So there was really a narrowing of the debate, and a lot of the press really kind of got behind the law. And so I just think, you know, you really have to be, you know, I think the opinion columns are good because sometimes they can explain things more clearly than an average reporter. But, you know, there's a point of view there, and you have to go beyond that and ask Avik Roy, you know, more pointed questions.
Yvonne, last question, short answer.
Okay, so just a bit of a spin-off of opinions from the scientific community on scientific pieces. I've always been curious if there's any rule of thumb about who to reach out to in the scientific expert community to provide opinions that are being reflected in the news stories about new findings and new drugs. Is there any?
You mean who you can get as a resource?
Yes.
Who else has written or studied this particular subject? And wouldn't a PubMed search tell you what else has been written about X?
Were you talking about, Yvonne, that...
Is that the question?
I'm not sure. Do you want to just repeat your question?
Yeah, my question is, I'm always curious to see who the reporter gets to reflect.
Like how does a reporter choose who they go to contextualize the evidence, I think. Right.
Yeah.
Okay, well, that's a really good question. Usually they go to whose name is on the press release, or the researcher who gives the quote to the communications person who puts it in the press release. And often they don't go beyond that. And they need to go beyond that. And that's what I'm saying. They need to go to other researchers in the field and sort of say, here's this new study about X, but you've done one that says Y on the same topic. And, you know, if you ask enough questions and you do enough research on who's been doing it, you can probably write a pretty good story that puts all this in context for the reader. And I just think it's up to the reporter to find out who else has been writing in this field. And sometimes you just want to ask, you know, maybe you have a doctor friend who gets all this. Well, do you know who's been writing about heart drugs or ED drugs or whatever you happen to be calling? But it's incumbent to go beyond that one source.
My impression when I was at ISIS certainly was that some of the health reporters did identify some ISIS scientists, and I'm just kind of guessing, that they thought, and to use one example, someone who's here was Mohammed Mamdani was often called by reporters who were doing a story about, you know, harms or benefits of drugs, and it was a story that he had nothing to do with. And somehow or other, I think he got credibility with them, and I think initially they went to him about his particular paper in the Lancet or JAMA or whatever, and you know he was pretty good at doing the kind of stuff that Trudy said. I think was sort of, you know, he knew his stuff. He kind of got to the point fairly quickly, and so my sense is, at least in Toronto, that the people like Teresa Boyle and others, Helen Brownswell, have a kind of Rolodex, I think, of people that they'll go to who are outside the person who's kind of, you know, whose particular study it is that they're reporting on. Last comment.
I was going to add to that. I'm probably a new face to most of you guys. I'm Jeff Keeler. I'm with Media Relations at St. Mike's. So to answer your piece first, Yvonne, a lot of what Andreas was talking about, media will reach out to us often, some of the names he listed, looking for a Canadian perspective, say if the study was published or based out of Harvard or something, to give it relevant context to the Toronto Star audience or even to the Globe and Mail, etc. So they'll reach to the media relations department often or directly to a researcher. In those cases, funnel them back to us, please. But we'll work to identify either with leadership or with the experts around the hospital to find the most suitable person who could talk to it or refer to someone else in the city to help provide that additional level of context that is needed so much, as you talked about, Trudy, with being able to provide full context and relevance to it, as well as more balanced opinion about what its meaningful impact could be.
I think one last thought. Always have an expert in your hip pocket, and I always have an expert actuary in my hip pocket, because I need help explaining some insurance things, or I'll need to know what's going on. And I was mentioning this to Ivan Oransky one day, and he said, I always tell my students that they need to have an expert, a medical expert in their hip pocket. So maybe some of you will become that expert someday.
Thank you very much, Trudy, and thanks to everybody for coming.